I welcome you again to the UNU-INWEH public event, the Science Talk. For those joining us for the first time, I say a big thank you for joining us. We are glad to have you. I am your host, Professor Grace Oluwasoya. Before presenting our distinguished speaker for this morning or afternoon or evening, whatever time you're joining us from, please note that there will be an interactive Q&A session at the end of the presentation. At that point, there will be room for comments, Q&A, and any other contributions you may have. Please type your questions or comments in the Q&A chat box, and we'll pick them up from there afterwards. Also, very quickly, let me remind you that all our previous Science Talk can be viewed on demand on our YouTube channel available at unu.edu/INWEH/Science Talk. Again, unu.edu/INWEH/Science Talk. The topic of today's talk is tackling antimicrobial resistance in humans and animals. So let's talk. Our presenter is Professor Herman Barkema. I hope I got that pronunciation right.
You did.
Professor Herman is a professor of epidemiology in infectious diseases at the United Nations University Hub, University of Calgary here in Canada. He is the UNU chair in infectious diseases in a changing climate. He founded the University of Calgary Faculty of Veterinary Medicine's Department of Animal Production and Health. And currently, he is, in a joint appointment with the Department of Community Health Sciences of the Cummings School of Medicine. I'm sure he will give us good details, when it comes in. His research program focuses on preventing and controlling infectious diseases in livestock and humans, including antimicrobial resistance, among others. He leads the Antimicrobial Resistance One Health Consortium and the Canadian Antimicrobial Resistance Network. He is a fellow and board member of the Canadian Academy of Health Sciences, and he has received many awards, in fact, too numerous to mention. He has published more than 450 scientific manuscripts and book chapters, Google Scholar H Index of 100, and has received more than $55 million in research funding, lectured worldwide, and is the most highly cited researcher worldwide in cattle diseases. So we are blessed to have presenting today none other than Professor Herman Barkema. Professor Herman, you have the floor. Thank you.
Thank you, Professor Grace. It's a pleasure to be here. So today I'll talk about tackling antimicrobial resistance in humans and animals. And this is work that we do with a lot of people at the University of Calgary and also beyond. So some of them are named here. I'll talk first a bit about antimicrobial resistance and use in humans, then in animals, then about the One Health approach, and then what should we do worldwide? So some history. In 1945 already, the Fleming, who invented penicillin in 1928, warned of the dangers of antimicrobial resistance. The time may come when penicillin can be bought by anyone in the shops. Then there is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug make them resistant. Those were prophetic words, and that's what we're dealing with right now. So the estimates of the O'Neill report and also the global burden of disease antimicrobial resistance collaborators are that an estimate of about 10 million people will die of antimicrobial resistance annually by 2050. And a lot of those deaths actually will occur in Africa, but also in other low and middle income countries. So worldwide, at this moment, more than 1 million people die as a result of infections that are resistant to antimicrobials, and nearly 5 million deaths are associated with antimicrobial resistance. This is not equally over age. If we see what happens with AMR, it's getting less in children, but the problems that we see is particularly in the elderly. It increased in the last 30 years with 80% in people older than 70 years. And internationally, the cost of antimicrobial resistance are already higher than HIV/AIDS and malaria combined. So if we look at Canada, we had more than 18,000 hospitalized patients that acquire infections in the hospital that are resistant to antimicrobials. And also in long-term care, this happens a lot. So if this is unchecked, the cost that we will have for antimicrobial resistance in 2050 that are now still 1.4 million are about 20 million. So yesterday, the New York Times published a paper on this. Modern warfare is breeding deadly superbugs. And it was the story of a journalist that in the south of Lebanon was caught into fire and was injured, and then also was infected by a fungus and lost a leg. And we see these kind of stories every day in the press about the superbugs. But it's not the headline typically like it is now in the New York Times. Because it is what we call a slow tsunami. So those superbugs are MRSA, methicillin-resistant Staph aureus, C. difficile, VRE, vancomycin-resistant enterococci. 1 out of 3 people that gets infected with that dies. The ESBL bacteria, those are particularly gram-negative bacteria, multi-drug-resistant Pseudomonas aeruginosa, antibiotic-resistant Strep pneumoniae, and Acinetobacter baumannii. And there are others that can cause these infections that are not treatable. So if we then look at the use of antibiotics and antimicrobial resistance, and on the x-axis is the use in a country, and on the y-axis the percentage of penicillin-resistant Strep pneumoniae, you can draw a straight line to that. Left bottom corner, you get the Nordic countries that always have been quite restrictive in the use of antibiotics. And if you go to the top, you get countries like France, Spain, Taiwan that use a lot of antibiotics. There are also a lot of countries where we don't have a clue how much antibiotics they use. I was just in Pakistan, India, China, and those are very high users of antibiotics and also have very high levels of resistance. So if we then look at climate change, also very important, the relationship between antimicrobial resistance and climate change, we don't have a lot of studies about that. We're getting more and more studies about the incidence of disease and climate change, and we see tick-borne disease, vector-borne disease going into countries more and more, and other diseases with global warming that affect people. But there's reason to be really concerned also from an antimicrobial resistance perspective. There's increased contacts between humans and animals. We see higher incidents of high intensity storms, water quality problems like we had in Pakistan a year ago. We have also food security. Then, of course, like I mentioned with ticks, the distribution of factors, and these ecosystems are shifting. So the WHO and also the FAO and the UN and UNWA, the World Association on Animal Health, they are very concerned and got together to work on that and formed the quadripartite. And with Keiji Fukuda, who used to be the Assistant Director General of the WHO, already a couple of years ago said that we need urgent coordinated action by the many stakeholders, because otherwise the world is headed for a post-antibiotic era in which common infections and minor injuries which have been treatable for decades can once again kill. So we are now at this moment doing a study commissioned by the World Health Organization, and we look at how is the prevalence of antibiotic resistance developing in the world. And we formed a large team all over the world, led by Dr. Diego Nobrega here at the University of Calgary, and with people from all over the world looking at antimicrobial resistance in the different syndromes, like blood system infections, gastrointestinal, CNS, urinary tract infections, and the lower respiratory tract infections. And we work closely together with a group in Indonesia, led by Ralph Hammers and Gilbert Lazarus. And we are now forming a report on that. And if you then look at resistance, like for instance, you have to look then per bug and per drug. So the combinations of this, and this is just one, E. coli and third generation cephalosporin resistance. And you see that it differs from region to region. And some regions, like Eastern Mediterranean region, we have a resistance of 80% in the literature. So we went in all the scientific literature. And if you then do that with blood system infections, there were 17,000 manuscripts that we needed to check. So that's why we really needed this large team. But you see then in the Americas, it is a bit over 30%. So it differs from region to region, and we see that with all kinds of drugs, but particularly problems in the low and middle income countries. So we're forming a tracker right now, and Mohammed Jokar is actually working on this, and we are going to make this all publicly available so that people can check trends in time, countries, bacteria drug combinations. So we're working hard on that. So if we then look internationally, many countries do not have an AMR plan yet, and that is really important. And then the ones that have a plan, a lot of them don't have the capacity to enforce regulations, which makes a plan actually quite useless. So why more in lower middle income countries? Now the access to diagnostics and healthcare and proper antimicrobials is really not good in the low and middle income countries. And if you see that people like me who travel over the world, when we come back, we have a more resistant gut. And the question then is that I would ask is, what is done by the high income countries to assist the lower middle income countries. We should not have the situation that we've seen with COVID, where countries like Canada or the United States try to gather all the vaccines for themselves and did not think of the lower middle income countries. And, even selfishly, where are the mutations occurring? Not in Canada and the US. This is one big globe, but which is a small village actually, and bugs don't stop at borders. We need to work together on problems like this. So if you then look at countries that I work with, and so like this is just, I picked a country, but it's the country with the largest population in Africa, Nigeria. The drivers of AMR include unregulated antibiotic sales, proliferation of unlicensed medicine stores, shortage of licensed prescribers, poor AMR awareness, which is even the case in high-income countries, and use of antibiotics in animals without prescription. And this is a picture from Pakistan, actually. This is a drugstore, and you just name what drug you want to get, and they will give it to you. So what has led to AMR development? So increased use, prescription taken incorrectly. There's no guidance when people buy antibiotics on the streets or in different shops. Sold without medical supervision, a lot of preventative use of antibiotics. During COVID, we've seen that antibiotics were used for viral infections a lot, and we saw also an increase in antibiotic resistance. We did a study on that, a systematic review. Then there's a lot of spread of resistant microbes in hospitals, but also in farms. People, when you go to a hospital, you are mingling with people that have infections there. Then antimicrobial residues, and of course, also the use of antimicrobials in animals. So we should not go on just in case, excuse me, but we should really go to cure all. Not cure all, but we should, now I'm sorry about that. We should go to the just in, and only when it's necessary. Not just in case, when maybe it's a bacteria, and just give it antibiotics. So how are antimicrobials used in livestock? Of course, we use it for therapy. I'm a veterinarian, particularly working with dairy cows. But so like broilers with E. coli infection, but it's also used a lot on prophylaxis, or in some regions also metaphylaxis. So feedlot calves on arrival, egg injection, dry cow trailer treatment, so at the end of the lactation, give every cow antibiotics. And then in some countries, growth promotion. It really works to enhance growth, but we use it actually. We need to use it in some countries because the husbandry and nutrition are not optimal. And then, of course, over-the-counter and prescription. So extra label use in veterinary medicine is common practice and needs to be common practice because drug companies cannot all put all claims on that for antibiotics on the label. It's often too expensive to do that. And we know that it works then for these diseases, but it takes a lot of effort to put it on the label. So the focus with these drugs is on residues, not on antimicrobial resistance. So there's very little attention from off-label use. Also of drugs very important to the treatment of human infections, like tuberculosis. So, and there is quite some mass medication and routine use. So, like I said, we use it as also as prophylaxis, and so that's economically driven. But the total picture is not known. And most farmers don't see the link between antimicrobial use in animals and antimicrobial resistance in people. And we don't know how antimicrobial resistance in bacteria in livestock actually goes to people. Is it by direct contact mainly, or does it also go with those bacteria in water, in runoff, and then through streams to drinking water and washing water? We then look at antibiotics in Canada. 80% of the drugs used for of antimicrobials are intended for use in production animals, and only 19% for humans. But you need to adjust for the number of animals, which is 20 times more than people, and also the weight. The cows are about 10 times our weight. But if you then correct for that, it's still 1.5 times more for animals than humans. From a lot of other countries, most countries, we don't have these data. Yeah? And then 73% of these antimicrobial classes are also used in human medicine. It's few the use of class 1, the really important ones. It's less than 1% in animals, but it still is a problem. And then what happens when they end up in the environment? Nobody measures what happens in water, for instance. If we look then all over the world, and this is from my research in other health in cattle, and if you then compare countries like China, Brazil, with Canada, we see that the problems are really in countries, not in North America, not in northwestern Europe, but we have our problems, and we need to do things here, but there's way more problems in countries like Brazil and in China. Here's a study that I was involved with E. coli in Pakistani buffaloes. Milk is produced in Pakistan for more than 50% in buffaloes, not only in dairy cows. And we looked at mastitis, so other health, and there we saw that 21% of these were ESBL producers and resistant to a lot of antibiotics. So if you then look at the relationship between antimicrobial resistance in animals, the environment, humans, you get what we call a confusogram. This was John Prescott published this, and others have made similar diagrams. And there's a lot of things that we actually need to check, because if you don't know how it is transmitted from animals to humans, you cannot prevent it. So we need, for all these wicked problems, a One Health approach. We more and more realize that we are together on this globe, not just humans all over the globe, but also the animals. And we are together in this environment. So we need to work together with people from all kinds of disciplines to address these problems. So the goal of One Health is we acknowledge the interconnectedness of humans, animals, and the environment, and also the complexity. It's not simple, and we need to go outside the siloed approach. Universities are siloed. Veterinary students and medical students don't even have one class together typically, let alone engineering studies or law students. But also, if we look at governments, people in the Ministry of Agriculture and Health also don't know each other typically. So there's no trust in working together. And you really, really need trust to work together to get to practical solutions. So AMR is a One Health issue. We have the same antibiotics used. Antibiotic resistance and the residues end up in the environment. Bacteria typically, so 70% of bacteria do not limit to one species. There are many factors contributing to the selection pressure there. And the similarities in what we need to do with antimicrobial resistance in animals and humans are quite clear. If we want to teach a pediatrician how to tell fathers and mothers of babies that no antibiotics are needed for this very likely viral disease, that's the same as techniques as we need to teach a veterinarian that works with dogs and cats or with cattle. And like I mentioned, what is the role of the environment? So working together, there are many, many stakeholders. It's not just veterinarians and physicians and of course pharmacists, but we also need policymakers, lawyers often. We need to work with the indigenous groups where the problems are way larger. And also, of course, with the pharmaceutical companies. So there's a lot of pressure from human medicine to veterinary medicine. And yeah, we know that it leads to AMR. And so the question is, does restriction of antimicrobials in animals actually lead to a decrease? Is there hope? Can we reverse this? So some initial studies, and these are a bit older studies in 2009, indicated that this may be the case. Ceftiofur, which is an antibiotic that is very important for human health also, and the chicken sector realized that, and they did a voluntary withdrawal in Quebec. And what you can see here is that the resistance in Salmonella Heidelberg in chicken, when they did this in Quebec, but also in Ontario, really dropped, and it dropped fast. So we did a study for WHO, and we took all the published literature and did a systematic review on this. And then you have to look at different bacteria and different kind of samples. And this is an example of it. It's Enterococcus in fecal samples. And there you see that in all the studies where they restricted, or most of the studies where they restricted antimicrobial use in farms, they saw that the level of antimicrobial resistance went down in those bacteria. And we saw that all over the globe. So there's hope for doing that in animals. But if you then look at people, the same was true. It was 24% in people. It was even higher in farm workers than in not farm workers. And that makes sense because in the farm workers, there's a lot of contact with animals, direct contact. While not farm workers, there's a dilution effect. They will also get food from other sources, but still there was a decrease in antimicrobial resistance. The resistant antimicrobials are not as virulent, not as sick-making as the ones that are not resistant. The bacteria pay a price to be resistant. So where should we go from here? Put lots of money in research and development to develop new antimicrobials, completely phase out the use of antimicrobials in animals. Or as veterinarians, should we tell those human doctors that get their act together first and try to delay measures? So if you then look at the first point, development of antimicrobials, there's a big void going on. In the last 3 decades, no really new antimicrobials were developed. And that makes sense. The pharmaceutical industry understands that if a new antibiotic is developed, that it will be shelved and only used for people with very resistant infections. And although that occurs more and more, it's still only a small part of the population. So, and it costs a lot of money to develop an antimicrobial, a new antimicrobial. We always at universities think if we spend $1 million to $5 million to a new drug, that's a lot of money. But it costs our pharmaceutical industry billions to really go through all the trials and approvals to develop a new drug. So they really focus on anti-cancer medicine. Yeah? But not on antimicrobials. So WHO made some recommendations, and FAO did something similar, and also the Organization of Animal Health, and they mentioned let's stop using antibiotics in livestock to prevent disease without diagnosis. So preventive use, for instance. But that's difficult when you don't have good diagnostic system in a country. So healthy animals should only receive antibiotics to prevent disease if it has been diagnosed in other animals in the herd. Makes sense. And then overall reduction in the use of all classes of medical important antibiotics in food production animals. And that's happening in a lot of high income countries. So antibiotics used in animals should be selected from those listed as least important. And that's where the majority of the use is actually. But still, we use high important ones as well. And that should also in a country like Canada really be more limited. So FAO made also some things like switching to extensive production system. Yeah, that's all nice. In low and middle income countries, we're actually switching to more intensive production systems because we need to feed our population of people. And so you see large farms occurring that are more intensive, of course, reducing stress, whatever that may be. Avoid mixing, very important. Good weaning practices, keeping stocking densities low. Well, that is not very economic. Reduce journey times. So in Canada, for instance, we should do something there. Calves still move quite throughout the country from Alberta to Quebec to the veal producers. And of course, breeding for natural robustness and disease resistance. We should use also a lot of the original breeds that are present in the countries and look where genetically that resistance comes from. But the concerns are the recommendations are beautiful, but they apply to livestock farming in developed countries, not in the developing ones, the low and middle income countries. And WHO, WAC, FAO, and UNEP only recently started to work together. It's great that they are, and there's a lot of movement happening, but that's only recently. So, and in many countries, the government, veterinary associations, livestock industry, and the pharmaceutical industry are working separately on this issue. We did a study in Canada and looked at what organizations are all forming antimicrobial stewardship plans, and there were more than 750 organizations in Canada developing antimicrobial stewardship plans on their own. So, and in developed countries, the pharmaceutical industries are cooperative and really are good to work with and stimulate antimicrobial stewardship. But when I travel to developing countries, low and middle income countries, I noticed that they're only interested in sales. Yeah? And there is where the most problems are in antimicrobial resistance. Not only related to humans, but also in animals. Yeah, we have problem treating animals in low and middle income countries because of antimicrobial resistance. So we need to act. Yes, resistance to penicillin has been there from the beginning, but that doesn't matter. We need to be proactive in agriculture. Also, as a veterinarian, I swore an oath that I will treat an animal when it needs a good treatment. We need a therapeutic use, but we need to develop targets for a reduction in use of antimicrobials. So in Canada, I was involved in this. I'm the co-chair of the advisory committee of the Public Health Agency of Canada on antimicrobial resistance, and the Public Health Agency developed a pan-Canadian action plan on antimicrobial resistance with 10 points, and it's a very good first plan, but there are 10 actions, but there are no targets. And we need targets. When a pilot goes from Calgary to Toronto, the pilot knows that he or she is in Calgary and is going to Toronto and needs to leave at this time and arrive at that time and can make a flight plan. If we don't do that for a thing like antimicrobial resistance, there's no direction, no accountability, and a lot less motivation to really do something. We need targets, objectives in each country to work on this. So the measures need to be commodity specific. It needs to be different for the chicken sector than it is for poultry is different than from cattle. And we need to put sufficient funding into surveillance. There's a lot of countries where we don't know what the levels are. And not only the levels of antimicrobial resistance, but also of antimicrobial use. And it will only work if farmers and medical doctors see the need, but also see a benefit. It doesn't motivate farmers and farmer organizations only if we talk about human health. They need to see the need and a solution, and there need to be alternatives for the use of antimicrobials. And the financial burden should not be too high for farmers. So, and communication there is really important. How do we bring that message to farmers, but also to the medical sector? So the guiding principle in reduction of antimicrobial resistance in animals is that disease can almost always be prevented by using good husbandry rather than prophylactic use of antimicrobials. When I go in the last month, I was in India, China, Pakistan on farms, and when I talk about antimicrobial use, I look at the incidence of disease and why these diseases are occurring. And that's what we try to stop. And then, of course, I also talk about the treatment of those diseases and try to limit the use of antimicrobials. But first, husbandry. So, and if a commodity, like dairy industry, beef industry, poultry industry, cannot keep their animals healthy without the routine use of antimicrobials, then they need to look why. Why is this necessary? There are always reasons for that. And we need to work together across the world using the One Health approach. So hopefully we have learned from the pandemic, and because these antimicrobial resistance genes will continue to develop in countries where lots of antibiotics are used without restrictions, and bugs don't stop at borders. Canada first doesn't work. America first doesn't work. Yeah, we need to work together. It's not the way to go. Also, if we think selfishly in countries like Canada, Northern Europe, or in the United States, those bugs will come. There is travel of animals and of humans, and the birds are flying over the continents and dropping their feces and with and with bugs and that are antimicrobial resistance. And we get water flowing over the earth and people traveling. What we also, when we talk with the lower middle income countries, we need to realize that these countries need to be able to feed their people. And that these farmers are economically dependent on the use of antimicrobials. So then we also need to think about our indigenous peoples. It is shameful in a country like Canada that we still have a lot of TB, which we don't have in the settlers. And that we still have a lot of reserves that need to boil their water before they can drink it, or even have to bring in water in. So it is, yeah, it is shameful that we have these diseases, and that's not only in Canada. That's similar in Australia and in other countries. And there's a way higher use of antimicrobials in indigenous peoples. We have more soft skin infections. We have a very high prevalence of AMR, particularly methicillin-resistant Staph aureus and TB. And there are nearly no studies done with indigenous peoples. And I say with here because if you want to work together, it needs to be with indigenous peoples, and the questions need to come from them. So, and they're really underrepresented in surveillance. So, when will we get really serious about this? And then, final message, all this together, AMR is like a boat. And if there are 5 holes in the boat, and we patch 4 of the 5, the boat still will sink. We need to work together to get this done. It's a global issue, and it's a global issue where animal health, human health, and people working on the environment really, really need to work together. So that is the end of my presentation, Professor Grace. So, and this, shows what kills me makes me stronger. What doesn't kill me makes me stronger. So.
Professor Herman, thank you. Let's start from there.
You're welcome.
I'm not sure I really agree with what doesn't kill you makes you stronger. It's like it's making you weaker by the day, you know. And anyway, let's start with this question. What is the approach in the diagnostic and assessment studies on AMR in a country like Canada, where significant amounts of antibiotics arrive from countries with no regulatory systems in place?
So how much can we actually contribute to what comes from low and middle income countries? Is more the question, Professor Grace?
Yeah, like maybe I should take it again. What's the approach in the diagnostics and assessment studies on AMR in a country like Canada, where significant amounts of antibiotics arrive from countries with no regulatory systems in place? In other words, more antibiotics are coming through the borders into Canada. So what's the approach here in Canada to combat that?
So we don't have a lot of antimicrobials actually coming from other countries to Canada anymore. That was the case, but that has become really restricted. So, and that's where regulatory measures actually work. We saw that a lot in farming. You could really order antimicrobials over the internet, and they were then sent to you. That has been cut off. That doesn't happen anymore. So fortunately, we don't see that anymore. But that's, in lower middle income countries, that's the least thing to worry about. It's more you as a farmer. We did a study in Uganda, and that was actually done more by people in the UK, and they then found that chloramphenicol resistance was increasing in cattle, and then they found out that actually these farmers bought chloramphenicol in human pharmacies to treat their animals because it really worked. Yeah, but we saw resistance then occurring in these animals, which then was transmitted to humans. So I think that's the worst, not the most important problem here in Canada, but that we need to tackle.
All right, a follow-on question.
Yeah, Herman, this is what I actually ask. The reason is you just came from countries like Pakistan and India, where I'm from Pakistan. I know how the antibiotics are coming to Canada. Almost everyone who goes back or a new immigrant, you will find the suitcase is full of antibiotics.
Yeah.
There is basically, what should I say, lack of trust, or they don't agree with the assessment, the local assessment. Anyone who has a simple flu will take the antibiotic that they have brought from the home country. So my question was like that this is not on the record. This comes through the people they use at home, but eventually that is contributing to the AMR status in Canada. So that was my question, that are you tackling this aspect? And if you are tackling, so how do you do that?
I am not tackling this at all. This is a regulatory thing. It's not allowed. And I don't know. I think the awareness among the Pakistani people coming back to Canada, and as you know, it's a significant part of the population. In Calgary, we have 50,000 Pakistani people. So, yeah, it happens with people coming back from India as well, because they can. Yeah, and they can get drugs there that we, for very good reasons, have not licensed in Canada. When I look at drugs in Pakistan, which, by the way, I loved being in Pakistan. What a welcoming people you are in Pakistan. It's really overwhelming. And it is a there are so many drugs sold with, if you look at the concentrations of drugs, actually, there's a factor 100 between the one batch and the other batch. There are drugs sold that we really should not use in people. So awareness in people, that is where we need to focus on. But that is really, really difficult. Also because people often have other problems that are more significant that they worry about. Yeah, and so that's a very difficult one, but it's not something that I can tackle. I speak about antimicrobial resistance, and I gave about 7 or 8 talks in Pakistan about that. But yeah, people are more worried about the smog in Lahore than about antimicrobial resistance. And I must say, having been there in that smog, I understand.
Yeah, thank you, Professor Herman. I guess that's the angle I'm coming from, because the drivers, in those LMIC countries are so different. There are a lot of critical issues. You cited Nigeria as well in one of your examples, and I can already tell you why people will revert to antibiotics. The health system, the health infrastructure is it's not available, it's not adequate. Don't let me say it's not available, it's not adequate. Access to it, affordability, to healthcare systems is so poor, poorly managed, poorly funded. And that's a country that if you resolve that issue in Nigeria, for instance, you kind of crash it for Africa because of the huge population, Yep. But there's a lot of system failure, driving this. So until we actually find a way to tackle the root causes, the real drivers, it may just be that we're just, is a lip service. I like the reframing of the problem when you start talking about the One Health. Yes, that's the way to conceptualize it. So it's a brilliant way forward. But again, the underlying issues are there. That's one. Then the causality. There are a lot of interlinkages: water, food, hygiene, and all that on the human angle. Before you layer it with the environment, you layer it with animals. So I understand the wicked problem angle, but to really pay attention to the solution required for this, are we really doing enough? Have we really identified the issues that needed to be tackled as a matter of priority, on this part?
Yeah, I knew that I was preaching to the converted. Yeah, we need to work together to make the health systems in the world better, and also to make the agriculture better and to also increase the quality of the environment. Yeah, and you talk about all these problems, but on top of that, we have all the conflicts in the world. Yeah, people in Gaza or in the Lebanon or in the Ukraine or in the north of Nigeria, this is one of the least problems that they think of. They think about survival. Yeah, and so there are you cannot address health, increasing health systems, making them better, or agriculture, if there is war. Yeah, so that is one of the things that we need to focus on. But in the countries that don't have a conflict, because they're so poor, they cannot really build a good health system, a good diagnostic system, because you really need that when you work on antimicrobial resistance. So that's why I really would like to work on the ground causes of these problems. You cannot just tell people that they should use less antibiotics when they get sick all the time. But people need to also understand that antimicrobial resistance is what we call a slow tsunami, and that we create problems by using all these, particularly the non-approved antibiotics, but also approved antibiotics in humans and in animals.
Thank you. Another angle to read is transhumans. The issue of transhumans is still a huge animal production practice at least in Africa, that I'm aware of, So how do you factor that into the confusionogram?
So transhuman?
Yeah, transhumans, how do I explain this? You said? Yes, those who travel with their animals, transhumans, practice of transhumans, when humans carry animals, from, places to places, and Yeah, that's the word for it, transhumans. They're not
Okay, yeah,
practicing the
sorry,
ranching
that was,
system.
yeah.
Yeah, they're not practicing the ranching system, but they rather travel along water courses, across borders,
Yeah.
like that, because of animal production. So how do you factor their own into this mix?
So, and I myself have very little experience with that, and that shows also that we need to work together, because these are cultural practices
Yeah.
that we don't want to stop, and so, but we need people that really work with have people practicing this to work on it. I myself, I work with farms. So I would be the last person to tell these people how to do this, and then if they cross borders, yeah, how does that work with with diagnostics and with the health systems? Well, that's even a bigger problem that we. Uh, Good point, Professor Grace, and that shows that we need to work together with sociologists, people that work with these kind of people, and it needs to come from them also. What do they see as solutions? It's not just telling them what needs to be done. It is working with them, and then yeah, see what the solutions need to be.
All right. More questions? Yes, Miriam.
Yeah, thank you so much. You mentioned this void in antimicrobial development in the last 30 years. And I think from one of your graphs between 1995 to 2007, it showed a really high cost of antimicrobial development. Do you have any data on whether that cost is coming down now with AI? Are there solutions for looking at other drug discovery using AI?
Yeah, so everybody looks always for the silver bullet, and everybody now looks at AI, and yes, but we don't know yet, because yes, in science we are really screening all kind of natural products, where we know what is in there, for antimicrobials. But that's only the first phase. The biggest cost of it is actually when it gets into the hands of a pharmaceutical industry. And when the clinical trials on safety, first in mice, then in animals, then in people, and then in larger trials, and then on efficacy, all need to be done. And it's only a small portion of the drugs that we test that actually end up, and so that we can use them in animals or in humans. There are products that we have then, and then we find out that they are too toxic to use in humans or animals, or that they actually are not very efficacious, have a low efficacy. So yes, I think AI helps, but the biggest costs are actually further in the pipeline. So I don't think pharmaceutical industries will really move in that direction. And there are so we have the CARB-X program from the United States, where money from government and NGOs is put in the development of drugs. Also, the Public Health Agency of Canada puts money in there to stimulate that, because it is not cost effective for antimicrobial, for pharmaceutical industry. So we need to help them to do that. But yeah, it is a problem that also a lot of the drugs developed in the United States not even get to Canada. And so let alone to other countries, less wealthy countries in the world that are not a big market for these pharmaceutical industry.
Okay, one last one. Our time is against us. behavioral adaptation, has it been explored in all this? Professor Herman.
Yeah, sorry, I didn't get the question, Professor Grace.
Yeah, I'm asking, has behavioral adaptation practices been explored within this context?
Adaptation of
behavioral adaptation in terms of,
so we work a lot on communication, and that's the way we need to change behavior. And people always talk about money as the reason why people should do things. Money, particularly in high-income countries, also is not the biggest driver, and I would say, fortunately, for people for their behavior. There are other reasons why people change, behave like that, and we need to find that out. Why are people doing these things? And use antibiotics, and often it is not economics. And it can be changed. Why? Are they using practices in agriculture that actually are not good for animal health? And we need to learn on what motivates them, why they do it. So we need to work with anthropologists, for instance, in this. And then we learn how to change, and then with communication experts, we need to learn on how to change these practices.
Okay, I guess we'll have to stop here because of time. We've run over time. My director is saying hi, Professor Kaveh Madani.
Hi, Kaveh.
Hello.
All right, thanks so much once again for your time and for the insight provided.
It was a pleasure. Thank you very much.
Hopefully very soon we'll have you on board again.
Yeah.
Thank you
and
so much.
You see, with AMR, we get to really large problems in health and in food systems in the world.
Yeah, exactly. All right. And to everyone who has joined us online, we say a big thank you. So see you next week. Bye for now.
Okay. Thank you. Bye.